Hey, it is 1 o'clock on the dot, 1:01. And so I'm going to go ahead and get us started. Thank you so much. My name is Tara Rains, and I'm Deputy Director at the Children's Advocacy Alliance. Thank you for joining us this afternoon as we meet with Director Richard Whitley and other directors from the Department of Health and Human Services to share what's coming up in this budget. And so I won't take long. Director Whitley and Maria and your team, if you all are ready to share, you are more than welcome to take it away.
Great. Hello, everybody. My name is Richard Whitley, and I'm the director for the Department of Health and Human Services. And, just we planned on just presenting highlights of our budget today, but it seems like it would be a little deaf to what's happening across the country and in our state if I didn't pause and talk about the OMB, the Office of Management and Budget letter that was put out yesterday at a federal level. So just want to say a little bit about that before going into our budget on what we know. Many of you know what we know because the information was not expected and fairly abrupt when it was sent out. But we have received a lot of questions from local agencies and what the impacts would be, but the letter, if you haven't seen it, Shannon will, one thing that at the end of this that I think that would be helpful to do is the group on this call, we'll send you the letter, the frequently asked questions that are out and use it as an update. I think since we consider you all community partners and many of you do the work that helps support efforts with Health and Human Services. But the letter did come from the Office of Management and Budget regarding temporary pause in certain federal funding. Just a few facts for us that we learned today. That states are, all states are currently unable to access the U.S. Department of Health and Human Services payment management system, PMS, and I have verified that with our state treasurer's office. That's the conduit that we utilize to draw down funds. And this precludes states from accessing funding for Medicaid and other HHS services. We hope that is temporary, but that is the current state right now, is that we can't access it. We actually tried to access it to make sure that we were current on all our drawdowns of funding, as probably all states across the country have tried to do. Given the number of questions I think that the OMB received, they did today issue a letter of frequently asked questions. And in that document, OMB clarified that the following programs will not be on pause. SNAP, the Supplemental Nutrition Assistance Program, or sometimes called food stamps. We do not know about the WIC program. Although administered by the same federal agency, prior to this coming out, we've had some changes in communication from the federal agencies, and so we're not getting a response or have not yet received a response on the WIC program, but certainly in that space of food and nutrition support, trying to find out those impact people's lives immediately. But SNAP is not included. The other program that is not included is Medicaid. In the frequently asked questions, clarifications from OMB. The other programs, small businesses, farmers, Pell Grants, Head Start, rental assistance. What's striking though is CHIP is not included in a current exempt list. So Medicaid is, but CHIP is not included on the exempt list. Again, this is the only information that we have that has been put out. but certainly would be impactful to people, especially people that moving out of Medicaid and likely doing better economically, and being able to still get coverage for their children through the CHIP program. But this is, again, all the information that we have at this time. We anticipate what that means is that the PMS system, the payment management system, the federal system for drawing down funds, will be reopened for Medicaid and SNAP and various programs. Now, lots of conjecture that the system's been overwhelmed by states trying to draw down federal grants that it's been shut down to retool it so only those approved programs can draw down. I have no idea if any of that's accurate. We just know that we cannot access it right now, confirmed through the treasurer's office. Finally, I'd say that for those federal programs that are impacted by this order, we don't have any other information at this time, but you know, in events like this that really can be disruptive, I would commit to you all that we would share information. Shannon Litz, my deputy in HHS, will be the point person for our agency and would share with you information as it comes out. Just because I think what we don't want to see happen is consumers who are often people living fragile lives, providers such as some of you, nonprofits who are fragile in your organizational structure, dependent on federal funding that may be a pass-through through the state. So I think misinformation can be harmful. So commit to you all that we would get information out as we get it. And that really is all. It almost is anticlimactic then to move into talking about our budget, but I just thought it was important to start by sharing with what we know, and we will try to go. We'll try to go forward with the presentation. Now we gave a high level overview yesterday, so to the legislature. We'll be following that and go agency by agency, and then have opportunity at the end to answer questions and talk about maybe where we go from here in terms of maybe scheduling another meeting or a focused one on any topical issues that you might have. But Tara,
I appreciate that. And I think that that's fantastic. We do have a couple of questions that have come in regards to this specifically. Would you rather take those questions now or just wait until the end with the overall Q&A?
You know, I think it would be appropriate to try to take them now, just to connect them to.
Okay, so the first question we have is from Stephen, and Stephen says, what percentage of HHS's budget involves FMAP?
No, I think I do cover that in my presentation.
So get excited, Stephen. So then why don't we'll just save these and we can just go back.
Okay, yeah. All right.
All right.
All right. So again, Richard Whitley, you know, in starting, I'm joined by the administrators for the department. We'll go through each division and the budgets, and with a commitment of trying to be as transparent as possible, where, you know, when we build our budgets, we're in a period where we can't share information. Then the agency builds the budget, then the governor takes our recommendations and turns it into the governor's budget, and then it goes to the legislature, and then that's the phase where we're beginning to go into, where they consider the budget and pose questions, and then it lands at the end of the session, you know, in a budget bill that actually funds our activities for the next 2 years. So in the past with the Health and Human Services Network, I think that we sometimes awkwardly did presentations at different times right after agency request, and then never really followed up with a presentation on the governor's recommended budget. And so I do think that timing is right this time to be able to go through this. On the first slide 2 and 3 outlines the department's mission and vision. The organizational structure being divided into the 5 divisions. And then the department has a variety of services. And, at the end, when we talk about our the priorities, I think it is just to understand, those of you that have been around Nevada a long time or worked with Health and Human Services, is we grow. We take new federal grants. We certainly are caseload driven on our direct services. But the complication of our agency really is that we do eligibility for programs. We fund programs. We regulate the programs that we fund. And then somehow with a free hand, some of our agencies then deliver direct services. Many of those are facility-based and focused primarily on behavioral health with psychiatric hospitals and for both adult and children, and lower levels of service in facility-based care. And then we have developmental services that has a goal of having people live as independently as possible in natural environments, but we still do operate some intermediate care facilities in Southern Nevada and have for a very long time. But those primarily our direct services are in that space, with the exception of the rural in Nevada. Our state has taken on largely the role of rural services in areas of public health, child welfare, children's behavioral health services, which is unique to many other states where they're either an entire state system or it is operated by the county in the case of local public health authorities. I'm already not following my script.
You're on a roll.
I was on real good. Slide, is that slide 4?
It is
Yeah.
slide
Okay, so slide 4 shows the breakdown of funds. And for this, it shows out the breakout of funds for Resilient Nevada, which are opioid settlement, and for Fund for Healthy Nevada, which is tobacco settlement. And, I think as ARPA funds, the rescue relief funds come to an end, largely largely in the space of Health and Human Services, our only flexible funds that the state really has to respond to emerging issues is opioid settlement and tobacco settlement funds. Most other funding is categorical and restrictive, either at a state level or through federal grants. And so we still have more work to do in this area with the opioid settlement funds. We have tried to focus on populations in accordance with the statute that lines out how we operationalize the settlement funds. We've tried to focus on various populations, and I think we're off to a good start with prenatal and early childhood. I think in this budget you'll see some additional projects in the space of adolescence. Primarily, you'll see that in the Division of Child and Family Services, in the space of juvenile justice, and an assessment center for youth who are criminal justice involved. Additionally, with kids aging out of foster care, we are supporting that with a combination of general fund and and opioid settlement funds. We're commencing with a lift in aging and disability to pursue a better understanding of the aging population that has been impacted by substance use and how that impacts housing needs and supports in the community. And so really excited about going forward with that and being thoughtful like we have tried to be with the investments in prenatal and early childhood and adolescent services. We also invested in veterans with a transfer to that department's budget account, and we're trying. I'm trying not to like step on any of the agencies that will go, but we're sort of the pitcher in some of these initiatives, and the agencies are the catchers. But also an area where we've done some work but need to do more is in the space of criminal justice involved. So we've invested some opioid settlement dollars in that space, but you'll hear from Medicaid about the waiver that they submitted from the speaker's bill from last session that required us to submit a waiver that allowed for 90 days of coverage of Medicaid in adult and children facilities, impacting both jails and the Department of Corrections, which can be huge with transformation when this population is being discharged, and also some savings, I think, to the counties who are currently contracting for medical services. That's a huge undertaking, but I bring that up because the funding for the contractor was actually approved last legislative session by to actually write the waiver, and Stacy Weeks utilized the same contractor that has been successful in other states. So it might take a year, or we don't know now with the federal shutdown on agencies, even on communication, how long it will take. But excited to get that back, and I think it is a way of improving outcomes for that criminal justice involved population. So just wanted to give some context of how these opioid dollars can be used for planning to stand up and leveraged with the federal match and lead to a direct service. Probably down the road, we'll need to invest in an electronic medical system we know for Department of Corrections, they use a paper chart, but some of the jails as well, with being able to have connectivity to community providers. But I really thought then our budget priorities. Well, our budget priorities really, the big one for us that if you've worked with our agency and the unintentional bureaucracy of just having lots of layers sometimes, is we're trying to align our business practices, and probably the one that the side of our department, which we're calling the Nevada Health Authority, similar to Oregon and Washington and New Mexico, our intent is to really leverage our ability to purchase healthcare. We started with pharmaceuticals and just more or less identified a problem of just in state government pharmaceuticals being purchased using different strategies, not understanding pharmaceutical rebates. And at first I thought we should put this with the purchasing division, and we gathered the information, and some of you may know Beth Slamowitz. She's done a lot of the pharmacy work in the past with legislation. She works in our opioid settlement program currently, but she put this all together, and we purchasing just, I thought it was a good idea, but it didn't really take. And so we sort of held to the tension of the discussion, and Stacy Weeks has really put together, I think, a thoughtful project that she'll talk about with the benefits of integration of public employee benefits, the Nevada Medicaid, data analytics, our regulatory agency, federally qualified health centers, and to really be able to integrate those programs so that we can get so that we can perhaps save money, but certainly improve quality and opportunities in our state. And this is not an approach that hasn't been taken by other states. It's and so she will talk more about that. I think what doesn't get as much focus is then the Department of Human Services, which really is all of the other divisions, as are aging and disability. We are renaming have proposed to in the budget bill that accompanies this reorg. We are proposing to rename the Division of Welfare and Supportive Services to the Division of Social Services, and really from a point of view of eliminating stigma. One of the budget items that we identified was related to family members who are raising children now who don't come in contact routinely with the welfare system and may not even consider themselves to be eligible. But if a grandparent is raising a grandchild whose parents maybe are substance use involved or criminal justice involved, making the services available to support that family, maybe even preventing the child from having more trauma if the family doesn't have adequate income to support the additional children. It really stimulated a discussion about stigma and how stigma can be a barrier. So on the surface, maybe not like a highlighted change, but definitely one that I think could be impactful in the people that we serve. The other divisions, child and family, and public and behavioral health, largely stay intact the way they are. I mentioned HCQC, the healthcare quality and compliance. That's to align regulatory of healthcare with payer, so that we can, sometimes payment issues are denote quality issues of care and vice versa. And also just to be able to actually stand up in a safe way, the health capacity of our state, tied to funding. It comes from CMS in a coordinated way. Our state licensure and our state certification for payment are in alignment on purpose. And so there is already an efficiency in that. So that's the purpose for those pieces moving, but largely the rest of the divisions stay intact. But what I am going to ask for from the legislature is flexibility that we don't currently have in a couple of ways. One is we learned from the pandemic that our health facilities need to work as a network, our hospital, like the private sector. So our hospitals, rather than being DCFS's hospital and DPDH's hospitals, I think that we need to be able to have flexibility between the divisions and put a frame around health facilities, so that with the shortages in nursing and social work and other clinical positions, we can maximize not only with state FTEs, but also with contracting. You know, those of you that work in the mental health setting know that we have to do primary care assessments of anyone in a psychiatric hospital, and doing that in a coordinated way, ensuring that that we're supporting the quality of care, but also good stewards of public money. I think that there's not only efficiency, but also support that can occur with that. I think that the other area, and I think there's a building block there again from the pandemic that we're not ready for, but we couldn't, Department of Corrections does direct services, and veterans with their skilled nursing facility in Las Vegas, they do direct services. We all had some of the same challenges during the pandemic with staffing shortages, and the rules of government don't necessarily support the flexibility. I don't think it's built for necessarily for these direct services and as nimble as it needs to be, quite frankly, if we're going to provide the services. Additionally, we have a lot of empty facility beds, and the hybrid model of being able to contract in, if we have an empty pod, rather than leave it empty in a hospital, perhaps contracting with a provider to come in and provide those services would be an efficient use. It's hard to find facility space, as hard as it is sometimes to find staffing, but these facilities are often difficult to find or place in neighborhoods or in communities. So on our side, on the Department of Human Services, those are things that we'll look at. And then I think taking a deeper dive on the social service side of populations. I mentioned in the beginning, aging. There really is in our state a non-system statewide. We have fragments of systems where programs are operated at a statewide level by aging, but there isn't like a local health department for aging. There isn't like a local child welfare program with all the connectivity and oversight and working together. Sometimes those sort of structures do help with coalescing efforts. Probably the strongest one is food supports, Meals on Wheels, and we saw that was really an instrumental part of during the pandemic for keeping seniors safe in the community. But what can we be deliberate about wrapping around that? As you all know, at a federal level, Medicare made changes in their rules about supporting long-term stays in nursing homes. So they no longer do that. And so really the drivers have all been from Medicare to keep people in their homes with personal care, home health, and hospice care. And so that in-home, the Meals on Wheels is a complement to that, keeping seniors aging as healthy as possible with some deliberate efforts. I think this restructure will free up our opportunity to focus on that population. And then I think in that space of other populations such as children, the child welfare, a fragmented system, but I do think that it will afford us to look at what the step down needs are with the Department of Justice settlement being signed. Kudos to Stacey Weeks for using Medicaid as the platform that we actually use to reach agreement on the settlement. We have a longer term strategy now ahead of us for funding children's behavioral health, but we have this immediate need now of services. I think with the state's Department of Human Services, it will allow us to define what is the need for the state to serve as a safety net. It's pretty well defined on the adult side just because of the need for the forensic evaluations. Much of our facilities space has been transformed to serve that forensic population or prevent the engagement in the criminal justice system. We need to be able to look at what role then the Division of Child and Family Services plays as it relates to a safety net provider. What's missing? My experience has been that everything happens by individual cases. And so to be able to look at the step down services needed for facility-based care from acute psychiatric hospital to psychiatric residential and other group home type settings, both locked and unlocked. We need the full complement, and the state has space. So I look forward to that being something that we can work on. But again, the ask of the legislature is to be able to have some flexibility to do these things. Human lives don't occur in 2-year increments. They happen in real time. And having some flexibility to be able to be responsive, I think would be a benefit to us as we go forward. And so I think I'll move first to aging and disability, and Dina can hit some highlights about some of the items that are in her budget or challenges that she can share.
Good afternoon, everyone. This is Dina Schmidt. Thank you for having us today. So we move on to slide 6, just is a quick summary of the operations of aging and disability services, some of the services that we provide. They're all listed here. And I know most of you are very familiar with those. And we move on to page 5 to talk about some of the accomplishments we've had in the last couple of years. I think it's important to just highlight, we did take advantage of the federal ARPA dollars to try to create some investment in our services. A couple of those projects were related to the Ackerman Center and getting children diagnosed for autism as well as services. And so we were able to, so far to date, we've diagnosed 979 new diagnoses as well as provided services to about 2,500 individuals. We also purchased some equipment to conduct some telemedicine equipment so that we could conduct accurate and efficient diagnostic examinations. That really allowed our teams out, especially out in the rurals, to take diagnostic equipment with them and provide that service in the homes. In the senior nutrition area, there's always a high demand there. We were able to serve an additional 1,500 people. In the residential facilities for groups, we did do a project where this is really outside the realm of ADSD, but we continue to see a demand and a need for group home settings. We don't have enough placements in any of our communities across the state. So we worked with partners and we did a notice of funding award to increase access to beds. And so what we did was we contacted all of our current group home providers to see if they could use funding to expand or add on to their current facilities. And so with those funds, we've added on 195 new beds, which is really quite impactful for us, and it helps us be able to find placement for folks, especially coming out of hospitals. And then we did do a business process reengineering across all of our programs, really looking at the business processes and how to centralize our workflows, remove duplication and redundancies. And so we had a lot of success in those programs, moving from anywhere from 66 days to 10 days to approve an urgent developmental services case, moving from 26 hours to 4 hours to approve service requests. Our call volumes, we used to answer about 80% of our calls were answered live, and now we're up to 97% of our calls being answered live. So really working on our internal processes to better serve the public. Moving on to page 6, you'll see our budgets by funding source. So the reduction you see on this chart in the federal funding area is about a 3% reduction. That is reflective of our ARPA dollars going away across all of our programs. And then the increase in state general fund is mostly related to caseload growth and rate increases in the previous session. So it's not an offset of the ARPA dollars, it's actually just an increase in demand for our services. And just so people are clear, I think there was a question about Medicaid funding. Medicaid funding for us is in the other category. So it is included in our other category in our budget because it's a pass-through. And moving on to slide 7, some of the major enhancements. Sure.
It's 9 in this.
Oh, sorry. Yes, I'm using my notes from yesterday. Sorry. Slide 9 is the major enhancements for our agency. We are asking for funds to create a standardized assessment for our developmental services, which is a very exciting opportunity. One of the things right now is assessments are done by our staff, and they are not always. This gives us the ability to have a non-biased assessment. So a team of people that do nothing but assessments and have no relation to the service side of that determination. This will help us determine the support level for individuals in a consistent manner and also help us with predicting our costs. Because we know that those assessments will be done consistently, it will help with our ability to project costs in our developmental service budgets. We're also looking for an opportunity to create 2 new positions for epidemiologists, one focused on health outcomes on newborns and developing children, and the second on older adults. Really having somebody, positions in our agency that can be leaders in analyzing the trends, the causes and consequences of health and disease, really looking at what is causing and how are opioids impacting those populations and what can we be doing to either prevent that or reduce costs related to those services. The next one is related to our intermediate care facility. Though it's a small facility, it's really important that that facility supports some of our most vulnerable individuals. And we really have had a hard time with staffing that facility. This is just creating additional supervisor positions to support the teams there, to ensure that we have supervisors on staff on every shift. The next one is transitioning early intervention services to a fee-for-service model. Currently, we pay a capitated rate per month, and then we recoup any Medicaid billable services. What we're trying to move to is swapping that model where they are reimbursed by medical insurance programs first, and then we pay the difference for non-billable, non-covered services. And lastly is the transition of Part C to, from the director's office to ADSD to enhance program oversight and to work together to continue to improve the NEIS system. So those are the major ones for me. With that, I will turn it over to DCFS.
Good afternoon, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services. So our first slide is at page 10. DCFS provides a wide range of services for children, youth, and families. Statutorily, we are required to provide child welfare, child protective services, as well as juvenile justice services. We have the authority to provide children's mental health services, including the authority for residential facilities. Right now, we operate 2. We have Desert Willow Treatment Center and Psychiatric Residential Treatment Facility North that we call that in Reno. So there's a list of juvenile justice services, children's mental health, child welfare, and then of course our administrative and support services. On slide 11, just some very quick accomplishments. Summit View Youth Center is our high security juvenile justice facility. It uses positive behavioral interventions and supports to provide skills to youth in the facility, and they had the honor of earning the Diamond Level of Achievement Award for their successful implementation of PBIS. Under the American Rescue Act, we had activities that included creating a certification system for youth peer support specialists, funding a nurse apprenticeship opportunity, and developing a network for intensive home-based wraparound services. Through grants, we were able to expand the Safe Babies Court into Carson City and Clark County, as well as expanding in Washoe County. We also have a $12 million 5-year system of care grant to build a provider network in Nevada. And then we also have a grant to provide intensive in-home family services that is administered out of our Southern Nevada office. Slide 12 is our DCFS budgeted funding sources, and you can see that we are 51% state general fund, 38% federal funds, and then 11% other. Our total budget about $827 million. Slide 13, our major enhancements are an intake and assessment and placement center that we will place at Summit View Youth Center. Currently, that facility has, I believe it's 96 beds. We only use 48, and so we will be using the rest of the facility to develop this intake, assessment, and placement center that would help us ensure that we are able to assess and evaluate youth in detention and county detention prior to them being recommended for a placement at any of our youth facilities, juvenile justice facilities. And so this will help ensure that they get out of county detention sooner and start earning progress towards release. The next slide is our our other major enhancement is extended young adult support services, which we call extended foster care. And this is about a 4+ year effort to develop a budget and the statutory authority and regulatory authority to expand foster care for youth from 18 to 21. And now I will turn it over to Cody.
Thank you, Marla. I'm Cody Finney, and I'm the administrator of the Division of Public and Behavioral Health. On slide 15, you'll see a summary of our operations. Our clinical services, our mental health services, primarily for adults, although in the rural areas, we do have some services for children, outpatient mental health, and crisis mental health. Regulatory and planning is that area that Richard mentioned where we're regulating private providers and other areas of the private industry primarily. And then community and public health, WIC, that you're, I'm sure, very familiar with, and maternal, child, and adolescent health sorts of services, kind of your classic public health services. Related to accomplishments this biennium, we've had some really good improvements in our vacancy rates. In some of our facilities, we're as low as a 7% vacancy rate right now, so we're very proud of that. We've had a very high focus on adult forensic services in this biennium. There's a lot of pressure on states to make sure that individuals who are awaiting services to be restored to competency, and generally they are waiting in jail, are admitted in a timely fashion. And we've been working on reducing those, both the number of people waiting and the time they're waiting. In public health, we've got active participation going with the academic health department with the university in the north, which has been very helpful to making sure that our staff are staying abreast of the latest public health issues. We've submitted our application to the Public Health Accreditation Board, which is very exciting and represented a lot of work for us. And we were recognized as an age-friendly public health system, which really demonstrates our success in lifespan services and supporting people and aging in a healthy way. On slide 17, you can see our the breakout of our budget, and we are about 27% is in other, and that includes primarily other federal grants, not Medicaid, and sources in that relationship. And then the general fund is about 36%. Major enhancements that we've got working on slide 18 include staffing for an additional 21 beds of adult forensic mental health services, the continuation of purchase of skilled nursing services in the community for adult mental health patients who are aged and infirm and require that level of care. We've got two small enhancements, fiscally small, that would allow us to update the process for people to be admitted to those adult forensic services, really update that to national standards. On 19, we can continue with those priorities. We've got in the Bureau of Behavioral Health, Wellness, and Prevention some increase in staff that is really about making sure that we can support community behavioral health providers as they're expanding, and some consolidation. One of our bureaus would be moving to the new Nevada Health Authority, that is healthcare quality and compliance. That is the regulatory piece where we license hospitals and other medical facilities. And then our environmental health would be consolidated with the Department of Agriculture. And I will pass it over to Robert.
Robert, you're muted.
Good afternoon. Can you hear me now?
Yes.
Okay. So the Division of Welfare and Supportive Services We primarily are a safety net for Nevada for people living in poverty or people working to come out of poverty. Our primary eligibility programs are a SNAP, also known as food stamps, temporary assistance for needy families, which is our welfare program. We currently conduct Medicaid eligibility reviews and approvals under a contract for the Division of Healthcare Finance and Policy. We have child care development, child care licensing, energy assistance, and we oversee child support for the state of Nevada. We have a program outreach where we go out to the community to connect in non-traditional sites. We're currently serving over 200 sites out in the community, in the homeless shelters, the hospitals, the mental health shelters, or mental health centers. We're actually work inside jails and prisons to connect inmates that are being released with our benefits so that they have a way to support themselves when they get out, with the goal of reducing recidivism. We have employment and training and workforce development with the overall goal of preparing Nevadans who are receiving social services to be able to wage gain, obtain true career paths, and reduce their need to social services. We have program oversight, which is quality control. We're a large agency. We have hundreds of thousands of cases. We oversee about 69,000 applications per month, and we are re-audited by the federal government to make sure what we're doing is accurate. And so we have our own internal oversight to make sure that it is accurate before the federal government gets here and tells us we're doing something wrong. Again, we do not consider our child support and child care licensing to be programs, so we are enforcement of those units. They are not eligibility programs, and we have information services like all agencies, our fiscal services, human resources, and IT technology. Our accomplishments this biennium, to be able to receive TANF assistance, adults must be working and in countable work activities. If for the entire caseload, 50% of the adults must be working to the level required by the federal government. And if there's two parents in a welfare household with the adults receiving assistance, 90% must be meeting those benchmarks. Nevada had never met the benchmarks for the caseload with two parents in the household. These benchmarks went into place in 1995. Nevada had met the benchmarks for the all family at 50%, but we did not believe we were ever going to meet the two-parent household benchmark at 90%. We actually did it. We were just notified for federal fiscal year 2023 that we met that benchmark for the very first time. So that was a huge accomplishment and shows that our workforce development and employment and training units are working. Our SNAP eligibility accuracy, there was a time when we were actually worst in the nation, or at least the very bottom of the nation, and we are now 13th in the nation and third in Western region at the top of eligibility accuracy. And what I didn't say during the hearing yesterday is we have been named as first in the country for at least 1 month as being the most timely. So we're getting those benefits out and we're getting them out right. Our vacancy rates are hovering at 6%, down from 21% November of 23. So we're onboarding our staff, we're stabilizing the caseload, and we're able to meet the needs of Nevada. And we have implemented a new food stamp program called Summer EBT that provides food stamp benefits for the summer of $40 per month per child for the 3 summer months if the child is income eligible and was receiving free or reduced lunch the prior school year. This is our biennium budget. As Dina said, other can include federal funds if it's passed to us from another agency. So there are federal funds within the other category, and there are taxes and fees within that other category. But primarily, we are 1/4 funded by general fund. Our major enhancements are the summer EBT program that I talked about a minute ago. That while that was an accomplishment, we are not funded for the future, and that is an enhancement for us to be able to continue moving that forward. Our next enhancement is a income verification system that we're required to have. We've had this income verification system for years, if not decades, but the federal government always paid for it 100%. They've stopped paying for it, so we have an enhancement because we have to start covering 25% of the cost. Two of our most exciting enhancements are temporary assistance for needy families. We are requesting to expand those programs using opioid funding. The first program would target programs that are subgranted through the counties for family preservation and support services. The second program is specific to income eligible families that are receiving TANF assistance that are guardians of children. If the children were removed from their parents' care due to substance use disorder, we are able to provide an additional funding amount above the normal welfare grant amounts. We currently have that program for guardians that are age 62 or above. However, through the years, we have seen that our guardians are much younger than that. There was a time when grandparents were 62, but grandparents are almost never 62 now. And I will pass it on.
So I'm going to move really quickly because I know we wanted time for questions. DHCFP, we are the Medicaid program. We also oversee the Battle-Born State Plan program, as well as our CHIP funding and Katie Beckett program. Katie Beckett is our lookalike Medicaid program for buy-in, families who can buy in, who make too much to qualify for Medicaid, but who have a child who has a disability. As you can see on the slide, we pay providers, we manage our budget. We also pay our sister divisions for their services, including ADSD, as well as DWIS for eligibility. DWIS is operating currently as our front door to the program. On the next slide, you'll see some of our accomplishments, and I apologize, I'm going to go through quite a bit quickly, just in the interest of time. And we went through these yesterday at the hearing, so hopefully some of you might have seen that. But we did stand up our new private hospital tax program. The value of this program is for this next state fiscal year is about $830 million in net gain for our private hospitals, which is a big deal given some of the rate challenges we've had in our state for supporting our hospitals, especially our rural hospitals. This is a big win for them. It also supports our behavioral health funded services through Medicaid. Under state law, we can use 15% of this funding for Medicaid covered behavioral health services. As you can see, we also have been working closely with the Department of Education on improving access for schools to bill Medicaid. This includes public school districts as well as public charter schools. We also recently got a new grant in this area, about $2.5 million, to stand up a billing vendor as well as electronic health system, a record system for schools. Richard already talked a little bit about the DOJ settlement agreement. We're working tirelessly with all of our agencies and stakeholders. We have a public stakeholder forum. If you want information and you don't have it about this, please let me know. It meets regularly and talking about our efforts to implement this with everyone. We are doing a lot in the dental space, and we'll talk about it in a minute, but we are seeking coverage for adult dental in this governor's budget. Next slide, please. We've been undergoing major procurements over the last 2 years. One is for our DSNP program, which really supports our Medicaid and Medicare dually eligible population, which has come with 4 new contracts for vendors, as well as some new services for our seniors and folks who are dually eligible, which is exciting and includes dental, personal emergency response services, fitness, and other new services. We are in the middle of our statewide managed care rollout. This will only include adults, parents, and children. It does not include seniors and the disability population. It does not include child welfare population. We're anticipating that our managed care program will grow by 10%, which gets us to 85% of our program will be managed care January 1, 2026. We did recently received our 1332 waiver approval for the public option program, which we are calling the Battle-Born State Plans. It also approved the governor's market stabilization program for a new reinsurance program, which starts in 2026. Together, we will see lower trends in the premium increases in the individual market. We are in the middle of a procurement as well for the carriers who will be participating. But we should have, there is a letter of intent to award that's public on the Division of Purchasing's website for 3 carriers. We also just submitted an amendment to our waiver for covering services in an institution for mental disease. Under federal law for decades, it has been prohibited that Medicaid federal dollars fund services in institutions which is more than 16 beds for substance use and mental health. We did get approval of substance use services, and now we are seeking approval to add the mental health services as well. Next slide, please. We just submitted another, this one's a full 115 waiver application for federal approval. There was a bill from Yeager last session that passed that really seeks Medicaid coverage for the justice involved population. It's 90 days pre-release, and so we're working with correction centers and jails and other partners to get ready for this. We also are now covering the juvenile justice population up to 30 days pre-release as of January 1, 2025. I had to take a minute to remember what year we're in. I forget. We are also working to implement centralized credentialing for all of our providers, which we hope will be easier for them to get enrolled and start providing services in Medicaid. Housing supports and services, they should be available to managed care recipients, which is 75% of our population who are impacted by homelessness or who have a behavioral health condition. Starting this year, we are also seeking federal authority to also cover the fee-for-service population. We are working with our hospitals and our NCOs to do value-based treatment design around quality, especially around maternal and infant health and community transitions. So we are not seeing folks cycling back into the ER. Next slide, please. Just to let folks know, just generally for the division, we have definitely hit a record and submitting 64 state plan amendments to CMS, which implements all I think we had over 50 bills last session that we are implementing. Some are fully implemented, some are on track, and some are delayed with various federal approvals that we're waiting on or system updates. If you have questions about a bill or anything, please reach out. We are almost fully staffed, 90% fully staffed, which is exciting for Medicaid. We completed the public health emergency unwind. Nearly half of those that disenrolled, according to DWIS, and our numbers show that they have re-enrolled since then. And the other thing we've been, dealing with, and some of you were maybe impacted by this, was the Change Healthcare cyber attack, which really prevented us from getting claims from some of our providers and being able to clear those claims through our clearinghouse. So we successfully navigated that, but I'm worried about the future of those types of situations. Next slide, please. Our budget, as you can see here, we're going from 15 billion to 18 billion, the majority being federal funds that we are requesting this biennium. Next slide, please. Real quick, we are asking for 2 initiatives to improve access to care. One is around using rebate dollars that we are going to be increasing through a single prescription drug list, and using that funding to support efforts that support providers who will participate in graduate medical education or other provider training programs. We will be doing this through their reimbursement structure. The other one here is really looking to reform our non-emergency medical transportation benefit. A lot of families don't even know they have it, which is really, I think, just shows that we're not doing what we should be doing. So we are asking for funding for a vendor and some staff to provide better oversight of our vendor that we currently have to do this work, but we are going to reform this effort. Next slide, please. There's a long laundry list of mental health system coverage updates, which we're excited about. New funding from that private hospital tax that I just mentioned. We can match that money with federal dollars, which in the total over the next 2 years, we're expecting over $200 million that we can invest in Medicaid rates, which is exciting. Mobile crisis is one, assertive community treatment, our ACT teams, community paramedicine. We're hoping to really build that out in this state. Behavioral health complex add-on, we're looking at a quality increase to help individuals who are stuck in the hospital so they have an option if the skilled nursing facility is the right level of care. Next slide, please. Partial hospitalization program, we're looking at rate increases, day treatment. We're adding coverage of first episode psychosis program, which is a national best standard and model. We're also increasing our rates for inpatient psych and detox, where we know we have some issues with our acute hospitals and freestanding psych hospitals. Next slide. This single preferred drug list is it's an ability for us to get a better deal on our outpatient drugs in the rebates. It's also going to help us with our pharmacies and providers, so it's easier for them to manage as well on their end. Everybody gets the same drug list. So it won't be different if you're on a different health plan. Everyone will know in Medicaid what their drugs are available. Obviously, we'll have to work through any hurdles and questions around that, but we're hoping that this will simplify and help us leverage more money, which we're adding as new revenue in the budget. Next slide. Adult dental, we are asking to add adult dental. We're going to be adding that coverage effective for state fiscal year of 2027, so July 1 of 2026. This will be primarily our preventative services diagnostic. There was a bill last session that added restorative coverage. We can now, I think, seek and get approval of that coverage with that because we're adding the preventative pieces here. So this is a very important item in our budget, and it will bring in savings to our cost. Next slide, please. Richard already mentioned that we're looking at working with the exchange to modernize our eligibility and enrollment system in the exchange. Other states are doing this as well and looking at ways to allow managed care recipients to compare their plans, their provider networks, the quality of the health plans that they're choosing. And we're hoping that this will help individuals make more informed decisions about their health care and really allow them to enroll in real time. And we're, next slide, please. So we're going back. And this is not.
And thank you, everybody. And then finally, these are the policy bill draft requests that have been submitted so far by the agency. And then we're happy to take any questions.
Thank you all for sharing. We have a number of questions here in the chat, and some of them were answered during your presentation. We're hoping to send out your presentation as well as a recording of this webinar to everyone who registered today. So I'm just going to go through the questions that we have in our Q&A, and if they're included in the slides, feel free to say, hey, they're included in the slides. We'll circle back to that. Feel free to and encourage people to review those a little bit later. So the first question we have is from Stephen. Stephen wants to know what percentage of HHS's budget involves FMAP. And I believe you covered that, Director Whitley, correct?
Yeah, we provided you with the pullout of our presentation that actually does have how much is federally funded.
Okay, perfect. And then our next question from Stephen also is, I think this was in regards to the federal conversation from the beginning. Does any of this or that, as he puts in the question, make any HHS items on tomorrow's IFC agenda problematic?
This is Richard. No, I don't believe so for tomorrow. It really is the unknown. And I just, as we were sitting here, I think I led with saying that the federal management system for drawing down money had been shut off. While we were sitting here, I'm told that our treasurer's office has reported that we can do drawdowns now. It still doesn't clarify for what, but at least for some of the categorical grants, we're able to draw down. And so our goal is to be current, but with drawing down so we can, proactively pay out, to nonprofits, which is largely what we do for services on that side. But there have been trouble, as I said before, with drawing down money. That probably is the most pressing current issue that we're facing. But in terms of IFC tomorrow, I don't believe that any of the items that we have are, based on what we know right now, impacted.
Awesome, thank you. And do you have any information regarding whether or not child care and foster care payments will be affected by this freeze at all?
So I can talk about the child care payments. When we knew that the state system was going down in December with the transition, we had issued 8 weeks worth of subsidies to both of Urban League and Children's Cabinet so that they could continue to make those payments in case there were any hiccups with the system. So they should be good into, I want to say, middle to end of February. Okay. So hopefully this is resolved before then.
Thank you for thinking ahead. That was Holly's question, Holly Kelsvin. And then we have a question from Noel, and Noel wants to know from the FRN graphs on slide 4, it appears that there's nearly a tenfold increase in the upcoming budget proposal. Is that correct?
This is the Fund for Resilient Nevada, yes. I think I testified on this yesterday, but we were very slow to start in spending the funding. Some of that's due to the way the statute is laid out. And so we did have this funding doesn't refer to general fund. So it's available. So we did do investments in this budget to state agencies rather than go to IFC and to interim finance committee and move money around. We actually budgeted with large amounts to, like I said, the in DCFS, the assessment center, standing that up, the extended foster care. There are new programs, all new programs, not supplanting, all new programs that we are standing up that really are leaning more heavily on the opioid settlement funds, which I think I said, in contrast to tobacco funds, they are a one-time settlement extended out for 20 years. And the tobacco settlement, back when Frankie Sue Del Papa did the settlement, they're in perpetuity. So as long as there are people purchasing tobacco products, we get a percentage of that fund. And that did go down slightly. So on the public health side, that is actually a good thing that we invest, 8% of the funds into tobacco prevention. But those two settlement funds are operationalized differently. Opioid, large amount, but time ended in 20 years. And tobacco, lower amount, but it's based on the sales.
Awesome, thank you. Eric wants to know more about the Office of Behavioral Health Certifications Bureau. What will this office be responsible for?
I just would start. I think the detail on that is still being worked on. And as we've said, this will come out as a budget bill, but in the Affordable Care Act, mental health is health care, and having an authority on that, we have had some discussion about a focus more on children, a need to distinguish with children. So it is sort of it will be detailed out more in our budget bill. We currently have a bureau that manages funds, not so much policy as it is a focus on every state gets a mental health block grant with a set aside for children. The thought originally was that would be the makeup of this office, but it really is the framework of authority and policy driving it. And Stacy Weeks stepped out of the room, but I do think that piece, as highlighted in the governor's state of the state, will be detailed in the budget bill.
Okay, and we have a question from Emma and a question from Eric that are both about reimbursement rates. And I saw Stacy step out. Is there someone there who you think might be able to chime in on those without Stacy being present?
Perhaps if
you want to give it a shot?
Yeah.
Okay. So the question from Emma is, can you provide additional information regarding the Medicaid reimbursement rate increase for community paramedicine?
Yeah, this is Richard. It's interesting because it is an area where Medicaid moved quickly on. Marta Jensen, actually, when she was the administrator, to get it approved as a service, but it's not been utilized in our state. So it's been approved, so there's no delay in that. It's that rate piece of a rate increase, which I don't know off the top of my head what that's being raised to, but to make it more competitive. And I think that Stacy mentioned in her testimony that in other states, partially due to the pandemic, but healthcare systems have really relied on this as a service to complement or to fill gaps in other discipline shortages for the healthcare system. And it never really took off in Nevada, even though maybe it was Assemblyman Oscarson's bill. I can't remember. I'm getting head nodding that I was right. Assemblyman Oscarson years ago established it. So it should be able to move more quickly if approved in our budget, because we don't have to wait for them creating it. It's been created. It's just making it the rate such that providers would utilize it and do some of the services that are already allowable.
Excellent. And the next question we have regarding reimbursement rates is about the behavioral health provider type 14 rates. And Eric wants to know if there's any information on what those are going to look like.
But he used to be the deputy. Let's put her on.
Correctly, behavioral provider type 14 is outpatient services. Any head nods on that from? I don't have specific information. We'll have to get back to you.
No problem, Eric. We'll make sure that folks reach out and get you that information. And then Eric also wants to know about the super board bills. There's a couple of omnibus board bills for mental health professionals. What can you tell us?
Could I do back on the rate piece? You know, one thing that I know that Stacy has been working on is pulling out a single pager on rates and the impact drivers. So we'll get that to this group.
Okay, perfect. And we will be happy to share that. Those are the questions that we have for today. If there are any other questions, folks, put them in the chat. I think those are our questions for today. Any final words, Director Whitley? We're gonna shift gears, and I'm gonna let Carissa Pierce, our Government Affairs Manager, and Holly Welburn, my Executive Director, talk a little bit about what CAA is doing in this coming session. But before that, I want to give you the floor for any final words.
No, I just, it was, I think we're thrown a bit by the actions at a federal level, and have really been working. I'll share this with you too when we complete it, but we are going through an exercise that we typically go through in the threat of a government shutdown. So in terms of, when people will be impacted, people being the direct consumer of our services and the providers we fund. And so we started the discussion late last night, and then we probably our presentation today is off a little bit, or mine is. I'll just note that my folks were good, but thrown a little bit on this. I think also the AG is looking at taking some action. The governor is looking at communicating the impacts. And so I'll share this document with you. I just want to make sure it's correct. But it definitely is a public document. But we have been through, gosh, I think it's been 10 years since they actually did shut down government. And, the odd thing I would just say that has made it difficult this time is, most of our folks are human service at the core. And so their interactions are relationship based, and the communication with the federal government has systematically been shut down, I think, in so much as from information on websites to communications that we were receiving weekly from our project officers to no responses on this. And so that is a different, that's made it more difficult when we've had threats of impending federal impasses on the budget that would result in perhaps a government shutdown. They always, as they always get to, in recent years, to the day before or a week before, and so threat averted. But we have had government shutdowns before where federal employees are furloughed, and the money's available, but the person to actually transmit it is not working. But we have no information on this really, just the frequently asked questions. And like I said at the beginning, The concerning part, largely Medicaid is covered, but CHIP is not. Katie Beckett is not. If you're a family who receives those benefits, you're largely impacted. A lot of our families on the food side receive, both SNAP and WIC. We know SNAP is exempted, but we don't know about WIC. And so, these impact people's lives. And so I think that just throws us a little bit. I apologize for that.
No, thank you. We appreciate you being nimble. We did get one last minute question in, and that's regarding the funds and budgets to increase child care expansion grants funding to help support folks who are being affected by inflation. Do you know anything about those grants?
About receiving them?
Yeah, or about requesting them?
Oh, I did see the announcement of them, but again, I don't know the status or we have grants in process right now that we've applied for, or we were told we were receiving, and they're silent on those as well. So we're trying to put together the prioritization, but I don't know the status of that grant, but I definitely can assure you that we will compete for and go after any federal dollars related to childcare.
Okay, perfect. Thank you so much. Okay, so with that in mind, I'm going to transition to Holly Walburn and Carissa Pierce for the next few minutes. Stay with us, folks. This information will also be interesting. And then I will say a final goodbye to Director Whitley and all of the directors in just a moment. So thank you so much.
Thank you. Oh, there we go. We got sound issues. We're sharing an office right now. Thank you, Dr. Rains. Thank you, Director Whitley, and to your crew. As Dr. Rains said, I'm Holly Wellborn, Executive Director of the Children's Advocacy Alliance. We are very grateful to the Department of Health and Human Services, who administer crucial programs and services for Nevada's children and families. And we're very grateful for you taking the time. And we look forward to working with you throughout this upcoming legislative session to continue to create a Nevada where all children can thrive. I also want to thank Director Whitley for addressing what's happening at the federal level. Quick announcement. This is just in. The Associated Press has announced that a federal judge has temporarily blocked the freeze. So, because of that, it will return to status quo. But CAA will continue to monitor this closely and provide information as we receive it. So please follow us on our social media accounts. If you are not subscribed to our newsletter, you can subscribe at the bottom of our homepage at caanv.org. And we'll be continuously providing updates as this unfolds and as other issues continue to unfold. But with that, as we approach the 2025 legislative session, CAA remains steadfast in our commitment to advancing Nevada's children's agenda. This session, we are focused on protecting foster youth federal benefits, addressing the child mental health crisis through centralized leadership, building a children's mental health workforce, and expanding access to screenings and assessments. And we're hoping to improve Nevada's early childhood system and expanding access to early care and learning programs in the state. For those who wish to learn more about our legislative priorities, I invite you to visit caanv.org, where you can find detailed information on the policies we're championing, including our one-page documents that describe some of those priorities in more detail. If you are interested in joining us, there are lots of opportunities available. You can find all of that on our website. I want to thank you again for being here and for your dedication to the well-being of Nevada's children. With that, it is my pleasure to introduce Carissa Pierce, our Government Affairs Manager, who will share all the ways that you can get involved in this upcoming legislative session.
Okay, thank you, Holly. So I'm sending a bunch of stuff in the chat for ways that you can get involved. You can also always reach out to any of us on the team and we can send you these resources as well. We have a lot going on. So Holly went through a little bit, but in the chat, I included our policy priority one pager. as well as the links to our weekly legislative calls. So every Tuesday at 11:30 a.m., we will be meeting together to talk about what bills impacting children will be coming through the session that week, where those hearings are at, and especially on our priority bills or bills that we think will be most impactful, we'll be giving some resources on how you can respond to those as well. Holly had mentioned we have a wonderful bill tracker on our website. So you can find that at that link and on our website. And that is a great way to stay updated on all issues related to children. We have a really great opportunity if you want more hands-on experience with working with families or working, excuse me, with as an advocate, where you will learn how to share your story, hear other people's stories, and then be able to share that with legislators through our Child Advocacy Ambassador Program. So that actually begins tomorrow. So if you're able to register, I'm going to include that flyer in the chat as well. And then finally, you can join us in the legislative building on March 10th through the 14th. I mean, we'll be there all the time, so you'll find us floating around all the time. But March 10th through the 14th, we have Children's Week. We would love to have you come and join us that week. And it'll be really great. So there's a link for all of those in the chat now.
Thank you so much, Carissa. And we know that you
there.
Oh, there you go.
And I think that's all my updates. We have a lot going on right now getting ready for session. I guess the biggest update is that our session starts next Monday, February 3rd, if you did not know. So you can come down to the legislative building. There will be a lot of people there, a lot of energy for the beginning of session. You can come say hi to us, start setting up some meetings. If you're interested in talking with legislators, that's a great opportunity.
Thank you so much, Carissa. Please take a moment to click those links so that you have the tabs open and download those documents. I also put Carissa's email address in the chat. She'll be our point person for all things legislative this coming session. We know you care. That's why you're here. Thank you for caring. Thank you for being here. Thank you for your commitment to Nevada's children and families. As always, we're here to support you and advocate with you. So please feel free to reach out if there's any way that we can do that here at Children's Advocacy Alliance. I will send out an email in the next 24 hours that has the slides as well as a recording of this webinar so you can share with folks who were unable to make it. I appreciate you all for being here. Thank you and have a wonderful Tuesday.